Thank you for coming. I'm going to introduce you to Dr. Mark Byrum. He is our board-certified oncologist at Premier Orland Park, and he is going to give you some update about the new fully funded clinical trial that we have going on. So we're very excited about that part. So take it away, Dr. Byrum.
Hey there, thanks so much for the introduction and kind of gave us the intro here that I'm going to be talking to you guys a little bit about a unique clinical trial that we have here at Premier Orland Park that we just recently started. So to kind of give you a little background and context is that about 1 in 4 dogs and about 1 out of 6 cats will develop cancer in their lifetime. And we see that roughly about 50% of dogs over 10 years old will die from a cancer-related problem, highlighting that we just like people that we're having. But on the positive is that pet oncology management is definitely improving. We know that we're doing better jobs with routine annual examinations so that we can hopefully capture or identify lesions or cancerous disease before it becomes symptomatic. And we might get to a treatment might not be helpful, but I also think that as veterinarians, we're getting better and better about how we do our physicals. We're doing rectals, we're doing more evaluations that are hopefully going to capture these diseases sooner than later. Additionally to our better annual exams is that we have better testing, that right now more than ever that we have access to advanced imaging like CT, MRI, also other assays or tests that help screen for malignancies such as BRAF mutations with dogs with urogenital tumors. And then outside of all of this, the human-animal bond continues to get stronger and stronger, that we have people that love their animals and that are willing to do anything and everything impossible, spending thousands and going the extra distance to help provide treatment because of the care that they have for their animal. Despite all of those things, that we're still facing a number of challenges when it comes to oncology and treatment. That number one, and this is probably the biggest concern that I get whenever our owners talk to me about, is that they're really concerned about quality of life because they have seen a friend or loved one go through cancer management and treatment. And honestly, sometimes it can be really challenging as a human to go through it, so that they don't want the same thing for their pet. Number two is that there's financial implications or concerns that when we're talking about multimodal approaches for therapy or even a single therapy, that we might be talking upwards of $5,000 to $10,000 or more for treatment. Also, having access to a specialist or care is probably one of the, especially in this current climate that we have, where it might take weeks or months to get in to see a specialist. So having that be readily available. And then lastly is like what options that we have to make sure that they are effective and that they are meaningful to that patient and helping them with their disease. So we definitely have some concerns when it comes to oncology and treatment. But we do have options. And I always talk to people that we have 3 pillars of treatment when it comes to oncology. We have chemotherapy, which is one of the things that I mainly can help provide. But we also have surgery and radiation. And then we have a 4th emerging pillar that's still not quite there yet, which is immunotherapy, which is a very attractive option that a lot of research is going into, especially when it comes to people. But because you don't want me in a surgical suite or behind a linear accelerator for radiation, I'm going to talk to you a little bit more about chemotherapy, because that's what I can do and what I can provide. And so when it comes to medical oncology, we're mainly talking about chemotherapy. And the goals behind that are really to help prevent or delay disease progression. So that might mean that we cut off a tumor and we're worried about it spreading, that we're probably going to talk about chemotherapy. Or if there's a mass that may not be surgical or resectable, like what options can we do to help try to prevent it from growing? And we have different kinds of dosing schemes. We have what we consider maximum tolerated dosing, which is a lot of people think about our CHOP protocols, or chemotherapy that's given less frequently but in higher doses. We also have metronomic therapy, which really strives to prevent blood tumor or blood vessel development to tumors and altering the immune environment, or we have small molecule inhibitors which aim at trying to disrupt communication amongst cancer that will prevent it from growing. But despite these options, that there are just inherent limitations. One is that tumor sensitivity, like, are we going to find a treatment that works, or is this tumor going to laugh at everything that we throw at it because it's just not responsive, like with sarcomas? We have concerns about tolerability, because although we might have a treatment, we don't want the patient to be miserable or vomiting its brains out while it's on treatment, because that's not a great quality of life. And then number three is, like, what options do we have? Like, we have a finite amount of drugs that we can use, and are they going to be helpful? And so how do we get past those challenges is really interesting. And part of it is that we're going to try to find new therapies that will hopefully be effective. Number two is that, can we find therapies, can we use them in different strategies to have a better impact? And out of all of this is that we want to ensure that whatever we do and whatever we try, is that we're going to try to ensure that the patients tolerate it well and it doesn't negatively affect their quality of life. So when it comes to new therapies, we have some options, and thankfully we've made some progress in the last couple of years with some new agents that are available for dogs and cats. Mainly the new ones that we have are for dogs primarily, but one that's getting a lot of attraction is a drug called Stelfonta, or Tignolol Tigolate, which is a little bit more fun to say. That is a fully FDA approved drug. It's an intratumoral injection for dogs with cutaneous and some subcutaneous mast cell tumors that is boasting a really high efficacy rate. I think it's an attractive option if a lot of our standard of care options aren't available. So, which is really exciting though, but we have something new in that front. We also have Tenovia, which is a newer drug for primarily that was just about until about this last year, just for dogs with lymphoma, but now it has full FDA approval and can be used for any type of cancer management. Which still has a really high response rate for dogs with lymphoma, and preliminary data for multiple myeloma shows that it might be an option to consider. And then lastly is what we have Laverdia, or Verdinexor, which is a conditionally FDA approved drug for dogs with multicentric lymphoma that we'll talk a little bit more. When it comes to these new drugs and kind of different strategies that we want to implement, is that one thing that seems really interesting or attractive is combinational therapy, which is in a sense using multiple different drugs that will hopefully try to have a meaningful impact. Whether that's trying to optimize or enhance maximal cell kill. Also, when we're using multiple drugs, they potentially have a broader range of interactions that will try to attack the cancer from different aspects, but also trying to slow cellular drug resistance, because ultimately that's why a lot of these drugs will fail, is that we know that the cancer becomes really smart and works behind or works against the drugs by developing resistance. So, and that's, we know combinational therapy has demonstrated a benefit. So for instance, when we look at the drugs CCNU or lomustine, looking at it, that roughly about 27% of dogs respond when used by itself. But if we look at other pieces of literature that incorporate CCNU or lomustine with other drugs, like in a lot-based protocol, and oncologists are big on acronyms, if you can't tell from that list, that LOP is the addition of other drugs like vincristine with procarbazine that will increase that efficacy upwards up to 52% in terms of response. But then also with L-asparaginase or LSPAR with PRED, is at upwards of 87% response. So combinational therapies definitely seem to be having a benefit or a little bit stronger than when using a single agent. And that's where our clinical trial really comes into play, that we're trying to use two drugs that we know have efficacy by themselves and using them together to see what kind of impact they'll have. The drugs in question that we're talking about are going to be Verdinexor or Laverdia, which I think Laverdia is a little bit more fun to say than Verdinexor. As stated, it's a newly conditionally approved medication for dogs with lymphoma. It's a unique mechanism of action because it's a SEEN inhibitor, which is just, if you're really into science and biology, tumor biology more so, it's a promoter of how tumor cells communicate and continue on. The preliminary data with it shows that it has an overall response rate of about 37%, which isn't too stellar. But whenever they looked at those dogs that had B or T cell lymphoma, and you have to always keep it with a caveat, there was a small percentage of dogs or a small group of dogs that had T cell lymphoma in this study, but overwhelmingly 71% of the T cell lymphoma dogs responded, which is very encouraging. It might be an attractive option for T cell lymphoma. The time to progression was about 43 days, but showing that maybe this isn't the most stellar of agents by itself, but it still has some efficacy. And then the other drug that we're using or wanting to see about this is with Doxorubicin, which is our tried and true. My mentor always told me that if he was on a desert island by himself and he needed a chemotherapeutic agent, it would be Doxorubicin because it has over 9 different mechanisms of actions against cancer. So it can be very helpful in disease management. And we know that across a wide amount of different tumors that it has variable encouraging responses, and upwards of 86% of dogs will respond. So it seems like this is a very potent agent. And so if we're going to be using these drugs together, it's important to use them in the correct fashion. And that's where the phases of a clinical trial come into play. So for those that don't know, and I always have to refresh myself, but phase 1 is that we're going to be looking for a maximum tolerated dosing or what we call dose-limiting toxicities. Phase 2 is when we're just trying to see the effect of what this drug has. And then phase 3 is really where we take head-to-head comparisons, trying to see if it's better than the standard of care. And then phase 4 often focus on kind of learning more tidbits or more benefits or risks that are associated with the drug. In the clinical trial that we're holding, it really is a phase 1. And I'll focus a little bit more about the specifics of that. The aims of this drug combination trial is really to, number 1, evaluate the tolerability of Verdinexor in combination with Doxorubicin over 42 days of exposure. So the first aim is a smaller time point. And then the second aim is a longer time point where we're really trying to see the chronic tolerability of combining the drugs over a full course of therapy for Doxorubicin, which would be typically 5 doses. A tertiary point of this is going to be efficacy for measurable tumors, but because of the logistics and how you have to approach trials is that we need to first see how safe it is and what kind of side effects that we have before we can even hope to determine efficacy. So we have some requirements that any dog, for the most part, with cancer is going to be eligible. And that diagnostic or that diagnosis can come from cytology or histopathology. Another thing is that we have to be able to give oral medications because Verdinexor, Laverdia, is an oral pill that's given at home. And we have to make sure that regardless of what disease setting that we're in, that we want to make sure that dogs have an adequate quality of life. So dogs that are very symptomatic and sick from their disease might not be the strongest candidates for this, but we want to make sure that they have a good quality of life before enrolling. To be included, the big thing is that dogs have to have a measurable cancer, and that's where it's really important. So they have an obvious mass that we can measure with calipers. They can have lab work changes like elevated globulins or lymphocytosis, or the tried and true if there's involved lymph nodes. We just need to be able, because part of this is that we're wanting to determine efficacy, we need to be able to monitor or measure the impact that this disease has. So the cases where we cut off a tumor and now we're worried about metastasis aren't probably going to be the best candidates because we can't measure microscopic disease. Outside of that, dogs have to weigh at least greater or equal to 9 kilograms. Part of that is because of how we dose the medication, that dogs that are really small are going to be hard to get an appropriate Laverdia dose or Verdinexor. And lastly, we have to have informed consent by the pet owner. There are some exclusion factors that are a little bit extensive, but not too bad. So things that might not say that this is the right patient for the trial might might include that if they've received chemotherapy within a week of study entry. Part of that is that we want to make sure that these drugs have enough washout period, that they're not going to have layering side effects if they're in their system. Another thing is that we have to make sure that doxorubicin is a safe drug for them. So dogs that have cardiac disease, and that does not exclude murmurs. We give doxorubicin to dogs that have murmurs quite often, but if they have significant heart disease like DCM or some other heart disease that might be exacerbated by doxorubicin because it can cause cardiac changes, it's not a good choice for them. Other than that, if they've already had doxorubicin or if they have MDR1 gene or the ABCB1 gene, collies, white on feet, don't treat kind of thing, those aren't going to be the best choices. Another thing, and this is the problem that I've run into already with some of my patients that I've wanted to enroll, is that if they have significant liver disease, that this isn't the right choice for them. So, if their total bilirubin is greater than normal, or if their ALT is more than 2.5 times the upper limit, this isn't a good choice. Part of this is because doxorubicin is metabolized by the liver, and if they're already having some liver impairments, we're most likely going to have more profound side effects. And so we should avoid this one. Another thing is renal disease, again, from metabolism of drugs. ECOG is more about quality of life, and side effects are how symptomatic they are from their disease, which will be something that we can kind of help with understanding. Dogs who initiated new supplements within 3 days of starting the study drug can't be on it. So they can be on supplements, but we have to give them a little bit of time. Or if they just don't have any really, if they can't take oral meds, because again, part of this study is having a drug that is given orally. So if they can't eat oral medications, this isn't a good choice for them. The wonderful thing that I love about this study is that it's fully funded. That's 100% is included. So that means all of the exams, all of the tests, like diagnostics, blood work, etc., all the x-rays and imaging that we're going to be taking, and all of the treatments are provided, which is very uncommon. Like, we don't usually get these fully funded ones that often. So this is a really big benefit. What's also really encouraging about this study is because it's a phase 1 and we don't know, we can't promise how effective, and we don't know how tolerable it's going to be, is that we're allotting $3,000 towards any study-related side effects. So that might mean anti-nausea meds, that might mean anti-diarrhea probiotics, or even hospitalization if they need it. We will provide upwards of $3,000 towards it to help kind of buffer in case that we recognize that this isn't the right drug for them. Just to give you a little bit, again, about overview, is that patients will undergo 5 doses of doxorubicin in combination with Verdinexor. The doxorubicin is once every 3 weeks, and the Verdinexor is given at home on a Monday and Thursday basis. So owners just have to put on some gloves and hand it to their pet to make sure they eat it. Periodic testing will be included. So we'll do lab work, we'll do chest x-rays, we'll do ultrasounds, because those are our staging to make sure that if we can monitor for progression. And the study is about 120 days in duration. So that includes the 5 doses of doxorubicin. Right now, we currently don't have any limitations on study enrollment. That might be subject to change, because as we enter, we have different doses that we're going to be trying. And so we fill those up before we can move on to the next one. But right now, we're pretty good that we can enroll. This is just kind of a study schedule. So it essentially boils down to 10 visits, including the day that we meet them. We have owners sign a consent form, we do some staging and start treatment, and then we'll periodically check in with them throughout this. And that's part of it's just checking in with side effects, part of it's checking in for progression, and the other part is treatment in itself. If you're interested in referring a patient, only a diagnosis is required. So cytology or histopathology can be performed with the primary care veterinarian. It doesn't have to be us. If you have challenges reaching a diagnosis, we're more than happy to try, but it's a-okay. We accept cytology and histopath without any problems. I will say blood work is encouraged, but not required. And that's mainly to screen if there's a hepatopathy or something like kidney disease or liver disease that might preclude them from trying the trial. We will have to repeat that blood work when they come in, but it won't be at the owner's expense if they agree to the trial. There are going to be some tumor types that I think inherently are going to be better choices than others. Those are going to be like lymphoma, transitional cell carcinoma, soft tissue sarcomas, or any type of metastatic neoplasia. The only tumor type at this point that I don't think is a good option is going to be mast cell tumors. And part of that is because we know that doxorubicin can cause histamine release. And so if we give doxorubicin with the mast cell tumor, there's a high potential that they could have like a anaphylaxis event or a severe degranulation event, which could be very catastrophic. So I would recommend not considering mast cell tumors for this trial. And all in all, that's pretty much the overview. If anyone has any specific questions, I'd be more than happy to answer them. Otherwise, I have put together our information here. So that's our phone number, our email, or our address. I love talking to people about cancer. And so if you have questions, or if you think that you might have a candidate or a patient that could be a candidate, I'd be more than happy to talk it over with you. And so if there are any questions or concerns, now's the time to ask.
Okay, so if we have a growth and we do cytology and it looks like a soft tissue sarcoma, you don't want us to do surgery and get histopath or remove it. You'd rather just send it over or try
I'm so sorry to cut you off. Yeah, that's a good question though, is that does this represent or does this replace standard of care? If owners can do standard of care, such like as a soft tissue sarcoma, I would recommend doing surgery to remove it. If they have cost concerns and maybe surgeries outside of their means, this might be an option for them. But I think standard of care is, even as I'm talking to my clients about lymphoma for management, I'm still talking about CHOP. I'm still talking about other options in addition to this. So I still give them all of their options.
Mm-hmm. Okay. But that doesn't disqualify them if we take the mass off or try to take the mass off
it potentially could. Yeah. So the question is, if you remove it, can they still enroll in the trial? Because we need something that's measurable. If I don't have something to measure, then they wouldn't be able to enroll in the trial.
Okay. So I'll talk to you first before removing it. Okay.
Yeah. Sure.
Okay.
Yeah.
All right.
Were there any other questions? So just so I understand, Dr. Byrum, so if one of the our referring veterinarians wants to send someone over to you, all of the testing beforehand, the client will need to pay for, but any testing after that point is paid for.
Yeah.
It's
so
part of the trial.
Yep, that's a good question. That if any testing that's going to be concluded after they enroll will not be on their dime, that we will cover that. So if you think that you have someone that is a little bit apprehensive about doing staging tests, that they just want a diagnosis and they want to go from there, that's part of the staging tests that are going to be included in the clinical trial. So just because if they have metastasis, it doesn't exclude them, that still is measurable disease. So it might be a way to get some more information about their health without having to pay for it all on their hands. But if they want that information before coming over, that's A-OK too.
And then after the initial diagnosis, everything else is done at Premier Orland Park, where you give the dosage and all the other follow-up and everything is with you.
Yes, that's also a really good point to make, is that everything will be done here at Orland Park, essentially because it's internal, it's a part of our money that's going into this, that we can't pay for lab work and such to be done elsewhere, that everything, including any adverse effects or such like that, should be handled through our hospital.
And then for any referrals that are coming to you, do they need to email you? Do they fill out a form? How do they send patients over to you?
Yeah, we're pretty easy here when it comes to making an appointment. So if you have someone that's interested in the trial, all they have to do is call and set up a routine appointment with us. If they could preference saying that they might be interested in the clinical trial, that's something to maybe of note. But we'll be able to talk with them, and there's not a special form or anything like that they'll need to have sent over.
Great. I think all my questions were answered. Did you guys have anything else you wanted to ask right now?
No,
Great.
Thanks.
I I will follow up by sending out Dr. Byram's slides to you. Also, you have it as a reminder. And if there's any other doctors that you want to share it with, that's great. And it also has his information, so you can email him directly on there. You also have my contact information. My name is Beverly, and I'm the referral relations specialist for the Premier Hospital. So if you have any questions for me about Dr. Byram's study or anything else that's going on with Premier, you can reach out to me either an email or a phone call, and I'd be happy to help you with that too. So thank you so much for joining us today. Dr. Byrum, did you have anything else?
No, thank you so much. And thank you for all the referrals. We're really happy. We've been here for almost about 8 or 9 months now. And so we're just getting some traction. And so we're here to provide any help that you guys need.
Thank you all and have a great afternoon.
Okay,
Bye
thank
now.
you.